Questions?
Governor, the Senate President yesterday criticized the rollout as confusing, that a lot of people don't understand how they can sign up even to get this done. Do you think the process is confusing?
I think in Massachusetts we made some decisions, and I think Michael spoke to this, to focus early on some hard-to-reach populations, which is different than what many other states did. And I think the reason we did that was we were concerned that many of these populations were not only hard to reach, they were vulnerable populations, and they were ones that we believed, as part of our overall strategy, we needed to make sure we got to first. And I do think the decision we made to focus primarily out of the gate on long-term care residents and staff, on hospital workers, on home health aides. Remember, home health aides are not only, as Michael said, in many cases, people of color, and PCAs are people of color, but they also serve, in many cases, especially home health aides, many seniors who are often people of color who have health issues that those home health aides are helping them deal with. So having those folks get vaccinated by definition will make things better and safer for the population that they serve and take care of. And I get the fact that by choosing a number of very targeted communities and populations that we felt we should start with, that would create a slower rollout and a slower ramp up than you would see where you just took big groups by age and said, go. But I do believe at the end of the day, we made the right decision out of the gate, and the fact that we're going to add literally dozens and dozens of sites that will bring our capacity, whether we have the vaccine or not, up to hundreds of thousands of people per week who can access and get vaccinated, should deal with many of the issues and the questions that people have raised. The one point I would make with respect to that is it's going to be important for people to go to the website, click on the site that's closest to you, and determine if in fact you're eligible, and if you are, make an appointment. But we are overbuilding here with respect to what we anticipate we're going to get from the feds by the time we get to the middle of February. And I certainly hope I'm wrong about that, and I hope that the feds give us the vaccine that we'll need to actually make sure that every single seat and every single appointment can get filled. But at this point in time, what I would say to anybody who's confused is go to the site, determine when you're eligible, find a site that's convenient for you, make an appointment.
Governor, the best practices, it seems like you've made some tweaks that Secretary Sanders was talking about, specifically with the federal pharmacy program. What was the issue there? Was some stuff kind of lagging or just kind of sitting there and not getting into?
Well, the thing to remember about the federal pharmacy program is you had to have enough vaccine available to serve 50% of your population on the long-term care program. Some states have much smaller long-term care communities than others. We didn't have enough vaccine to serve the size of the population that would be represented by 50% until we got to the second week. The rollout itself, they're planning to make 3 trips, right? They've done 1. Are they in number 2 yet? They're just still working? So far, the take-up rate on residents has been pretty high, sort of 80% plus. The take-up rate on staff has been more like 50, and that's part of the issue.
I'm asking for other states that are using their best practices. I mean, some of the ones that have better administration rates, so to speak, based on some of the things you talked about, how they're doing it a little bit differently. But are you using any of their some of the states that have it better?
Well, some of the states made a decision to not participate in the federal program. They had much smaller long-term care communities than we did on a per capita basis, and certainly that decision gave them a lot more control about the rollout. But most of what I would describe as the larger states that have the greatest number of long-term care facilities on a per capita basis are participating in the federal program, and I've talked to a bunch of governors who have some of the same issues and concerns about the pace of that we have.
Governor, why doesn't that state have
check with the state of Connecticut? I mean, they seem to be doing so well, and I'm assuming that many of their priorities are similar to yours: nursing homes, healthcare workers. You can check the CDC website. People are keeping score
Connecticut, to the best of my knowledge, did not put in their initial priorities many of the vulnerable populations that we did, which we said would take longer because of the nature of getting to them. Mobility is a big deal. If you can't get to a site, which many of the populations that we chose to serve first can't do, you have to get to them. Secretary Sutter's talked about the fact there's 850 locations involved in serving many of the people who are part of that congregate care community.
So
that's a lot of outreach and a lot of work.
As you look at your decisions, there's nothing you do differently. You think that everything's been spot on?
I think, well, look, if I had had a better understanding and more insight into a number of these issues, I might have thought a little differently about them. But let's all remember that we were making the decision, especially about healthcare workers and where we were going to put them in this puzzle at exactly the same time we came out of Thanksgiving and our daily case count doubled, our percent of positive cases doubled, and our hospital admissions took off. And from our point of view, we looked at that and said, we have got to make sure that our healthcare system is going to be able to serve the people who are going to be dealing with COVID and continue to be able to serve the people who need to access the healthcare system but aren't dealing with COVID. And thankfully, we now appear, for now, to be on the other side of that surge. But that's what was taking place at the time we were making some of these decisions.
Governor, why doesn't the state have a central
Can I let the woman behind you go, Sharman?
Why doesn't the state have a central registration website? Some other states have one giant site. You can go on now, put in your DOB and whatever.
First of all, where's the map?
Site, but it leads to some others, so I just didn't know if there's any plans to have one central registration site.
We're going to have you'll be able to go on the website. You can go on the website, determine if you're eligible on the site, find a location that's providing vaccinations that's convenient to you, click on it, make an appointment.
No plans to streamline that, though.
How much more streamlined would you like it to be than that? That's pretty, look, I think that's, for most people, being able to determine if you're eligible, where the site closest to you might be, and how you can make an appointment on that site, all at the same time, should be, for most folks, a pretty easy way to make that happen.
Last night, the Department of Public Health told cities and towns that are going to be capped on the amount of vaccines they're going to receive through the end of February. Some are expecting hundreds a week, now they're only getting maybe 100. Why this sudden limit on cities and towns?
Well, it depends upon which city and town you're talking about. In some cases, it has to do with the amount of vaccine they still have available, right? And in some cases, it has to do with the amount of vaccine we get from the feds.
But has there been a change in direction from the feds that prompted that? Are you planning to move more into the mass vaccination sites? Because the cities and towns are saying this is sort of a abrupt change from the understanding what they were.
Do you want to speak to this?
So the request we get, Matt, the request we got for this week was 2.5 times what we have for supply, one. And secondly, that's everything. And what we are doing now is asking everyone, what do they have in hand? What do they have scheduled? And then if we can, we will do the delta of that. So if a town had scheduled for this week 500 appointments, let's say, and they had in hand 300, 350, then what we tried to do in doing the allocation was to give them the delta so that they would have 500. So this is, as we have said, we have a constrained supply from the feds. We clearly, mega sites are important for us because they are efficient. And so clearly having the mega sites are important to us. Retail pharmacy, lots of sites, wherever the map is. Lots of sites for people to be able to get to, and then distribution to local boards of health. But in all cases, we now are seeing what you have in hand, what's scheduled, and then if we can give you whatever the delta is.
Governor, I wonder if you've had any, last time we talked to you regarding your communications with the Biden team, it was actually before the inauguration, and they had said you can really just expect to be getting the same amount of doses that you had been getting. Is there any sort of an update, especially given that in order to meet that administration's goal, you said we need 25% more doses? Is there any sort of an update on the number we're going to be getting here in Massachusetts?
The only update we have from the administration at this point is sort of an informal one, which is that they are currently working on what will be sort of their rollout plan going forward. But we haven't received specific guidance other than we should continue to expect for the next few weeks what we got the last few weeks. No less.
So the point, I guess the bottom line is you really just don't know that you're going to have enough doses to administer to all these people.
If we just continue to get what we've been getting and we do what we're planning to do over the next 2 weeks, as I said, we will have empty seats and open appointments that we won't be able to fill. Because our goal at this point is to go as hard as we can for the next 2 weeks in anticipation that we may have more. But if we don't, we will have empty seats and open appointments.
Governor Christie, whom we know well, has said that she doesn't even know how much vaccine the federal government has. Things were such a mess under the previous administration. Do you know how much vaccine you have and where the bottlenecks are?
Well, I think part of my answer to your question, Jonathan, is what I said to Sharman, which is that's why we've only gotten sort of an informal sense from them about what we can expect going forward. I think Mary Lou talked about or the Lieutenant Governor talked about the fact that virtually all the vaccine that we have received as a Commonwealth has been distributed to either the long-term care community through the pharmacy program or to providers, both community providers, hospitals, congregate care settings, and others, to begin the process of either first dosing people or second dosing people. I mean, one of the things everybody should remember here is that people keep score on this as if this is a one-dose vaccine. It's not. I mean, everybody who gets a first dose needs to get a second dose. And one of the reasons I have said to you many times at these press conferences is the thing I would like the most is more visibility into what's coming next, is so that we can make appropriate decisions with high degrees of confidence that the vaccine we put out the door for first doses will work and that we won't need them for second doses at some point a couple of weeks later. That's in some ways one of the greatest challenges I think we all have on this, which is how much of this can you actually first dose with people? You can make estimates, which everybody does, and we've been careful about that. But you can't literally say, as you look down the road, especially when you have the new head of the CDC saying, not exactly sure, you got to be careful about just first dosing and worrying about whether or not you're going to have second doses when you need them 21 and 28 days later.
So you shipped 98%, less than 50% has been administered. So hospitals are holding it, nursing homes are holding it, and they're not giving shots. Can you pull it back? Can you send it to someone?
Well, that's why don't you speak to that?
So instead of just allocating out, the adjustments we've made is literally hospital by hospital, understanding what they had in hand and then what was being planned for the next week. And we've made it very clear. We put out the guidance last week that you have 10 days from the time you receive to administer. And if you don't, then we will redistribute. Now, the one thing I'd say about redistributing is, right, it's an mRNA vaccine. So it's a fragile vaccine, right, that requires certain cold storage and the like. So these are not vaccines you just sort of pick up and, walk across town. So what we want to do is to make sure that people are really conservatively planning their allocations and that we understand what their schedules are. And then we're coming now back to monitor this week what they said, what they've scheduled. And yes, we have said we will redistribute if we need to. On the federal pharmacy program, we finally were able to get the federal government to allow us to, one, halt any more deposits into the federal pharmacy program, and then literally redirect 20,000 of the doses from the federal pharmacy program into retail pharmacy. And that's this week, and that is where you see some of these, the proliferation of pharmacy sites, is that 20,000 has been redirected into those sites. So we're being very now, well, we've always been monitoring this, but we really want to understand what you have in hand, and then what's scheduled, and then we come back to check, and then you may get a next allocation. And this week in the hospital systems, there is no new allocation because they have plenty of doses in hand for their first and second doses.
Secretary, the one I was trying to ask earlier was,
Yeah.
why did that best practice change? Do we not have information? Because
So again, we're like, what, 5 weeks into vaccination? And in the beginning, because you don't get from the federal government, the governor and I were talking about this earlier, we get like an allocation. And so when we first started to order vaccines for hospitals, say the first allocation from Hospital X was for, say, 10,000, just making up these numbers, right, 10,000. So we put that allocation in. And if it was Moderna or Pfizer, then 3 weeks later, we put in another 10,000 doses to make sure they had the second dose amount. And what clearly hospitals and everyone over anticipated what the uptick was for vaccines. I mean, I think you heard Michael Curry talk a little bit about that. We've seen that in the long-term care facilities where like about 50% of the staff have accepted vaccines. It's about 80, a little bit over 80 for residents. So I think in the beginning, people were enthusiastic about vaccines and, you know, anticipated an amount that turned out not to match what the acceptance rate was. And so we've now gone back with folks to readjust it down significantly. And that is all part of like the maturation of the vaccine program. You know, and again, we look forward, and with constrained supplies, we need to get doses out, distributed, and into people's arms as quickly as possible.
Does that tell you that there's an amount, a good amount of people in phase 1 who didn't want?
Well, again, and it's not to overemphasize the long-term care industry, but in the long-term care industry, of which we have about 80,000 individuals who are either served or residents or workers, it's 52% of staff have currently, so at this time, because we're still rolling out, 52% of staff, and it's about 84% of the residents. So we continue to work, and on the hospital side, I just don't have the hospital data in front of me in terms of the acceptance rate. But we clearly need to keep working with people.
Can you clarify, will the state wait until everybody 75 and above is vaccinated, and then you will open up to 65? Or what sort of percentage are you looking at before you go to that
Right.
65? And then when do all the 65 plus get done before?
No, thank you for that. It's not a linear process. This is obviously, we're trying to build, as the governor said, build the infrastructure and the capacity. So by February 15th, right, we'll have staffed capacity for vaccinations, about 305,000 doses a week. So we're trying to build the capacity, right? And then see what we have available, and then just continue to start to open up. It doesn't mean that folks in phase 1, like the COVID-facing healthcare workers, can't continue to be vaccinated, but we want to continue to move the progress. So it's not linear at all. It is trying to literally determine how safely we can expand eligibility and not have what has happened to some other states, right? Where you're eligible, good luck trying to find a vaccine appointment.
And how can folks people over 75, who might not be internet savvy, might not be able to get up, how do they book their?
Right, so at 1 o'clock today, I think it is, this afternoon, the wonderful Executive Office of Elder Affairs is putting out a massive communication to their network of councils on aging, their community groups and the like, talking through 75 plus eligible as of next Monday, and reaching out to individuals who are over 75 in their communities, ask if they need help to get them vaccinated. That's one thing we're doing, obviously. So we're just trying to get the information out. There are certainly some who will go online and do it, but we're really putting the message out to community groups who are well connected to this to help folks.
I just wanted to ask you a data question. Every day sometimes we get numbers from the governor on the supply and then the doses administered, and then we get a report from the Department of Public Health, and then we get a report from the CDC. The numbers don't line up, and we're trying to figure out which are accurate, and we're getting messages from viewers saying that they're confused.
I would never dispute that answer. So the governors and the DPH the governor pulls from the DPH daily data. The issue between CDC and the state is literally just the timing. What time the CDC pulls the data versus what time we pull the data to report is literally just a timing issue.
Secretary, when you move to the phase of
I'm sorry?
When you move to the phase of the comorbidity, mobility, the second phase is phase 2.
Right.
Or I guess it'd be the third phase, we have comorbidity.
No, it's so individuals 65 and over, or individuals with 2 comorbidities. Sorry.
The question is, are you guys going to ask people to prove that they have comorbidities?
It's a self-attestation.
It's a what?
A self-attestation. When you go online and find where you want to get vaccinated, there is a self-attestation that you also fill out. It's up now.
Is it fair to call that an honor system then, to determine if they fall in or are eligible to receive it?
Just like it's an honor system now if you're a home health aide. I mean, this is based on a self-attestation process.
Thanks, everybody.
Can I speak to the CDC? Can I just speak to the difference between the CDC data and other people's data? I mean, honestly, since this process began, there was the COVID tracking project, Johns Hopkins, COVID exit strategy, COVID Act Now. Is there any other ones? Are those? There were a lot of websites all around the country that were aggregating data, mostly from the CDC, and I would look at it all the time because I was doing the same thing you all do, which is compare me to other states, and I would constantly be calling Mary Lou and saying, this data on COVID Act Now, this data on Johns Hopkins, this data on COVID exit strategy, this data on the COVID tracking project, it's not the same as the data that I get from you. And, you know, frankly, it's making me a little cranky. And the big lesson I took from that is in the translation from what the state reports either to me or to the federal government and what eventually lands in the CDC reports, which is where most of the national scoreboards are being kept, they're just different. And some of it has to do with timing. I think some of it also has to do with definitions, and I think some of it has to do with what we might call an A in our database. They call, you know, an A squared or something like that. And I've just kind of accepted it. Like I look at the data on the COVID Act Now site, and if I look at the COVID Act Now site, which is mostly CDC data today, I can promise you that I will find stuff on that data site that I will look at and say, that's not consistent with my view of the world. Now, is it like hugely different? No. Is it different enough to get my attention? Yes. Is it relatively different across lots of other states so that for comparative purposes it still serves a useful purpose over time? Absolutely. I mean, so when I'm looking at hospitalization data, when I'm looking at case counts per 100,000, when I'm looking at a lot of the other elements that are on those sites, for my purposes, they are helpful in helping me create some degree of relativity with how I'm doing relative to others. And I'm competitive enough to care about that. And if I see something on it, I'll call somebody in another state and say, help me understand why your numbers are this and my numbers are that. And that's why I ended up calling a lot of governors about this nursing home thing. Because I was looking at our data and I was looking at their data and seeing they were having some of the same issues with getting shots in arms that we were, and discovered that many of them had exactly the same issue we had. So I think those sites are incredibly useful, and I think the CDC data is incredibly useful for the same reason, as a relative measure. But if you're looking for precision across all those data. There are 100 data elements that we send every week to the CDC. 200 now. It's just, you're not going to get boom, boom, boom. What you will get is a pretty decent sense about relative position. And honestly, one of the things that's been particularly interesting to me, and I'm carrying on here, is when I line up hospitalizations per 100,000, which to me, you can't fake hospitalizations. The number of people you have in the hospital per 100,000 with COVID and the number of people you have in the ICU, that's a pretty solid number, right? When I line that number up with cases per 100,000 or positive test rates, you can learn a lot about who's testing and who's sort of testing. Because there are plenty of places in the United States right now that have a lot more people in the hospital that are COVID patients on a per capita basis than we do, who appear to have positive test rates and cases per 100,000 that are dramatically lower than ours. Now that says to me that I'm doing a lot more testing in Massachusetts than they are. So I wish I could give you a better answer on how this lines up, but it's just always going to be a little messy at the end of the day.
Reaction to people going to other states. We've been hearing about, and particularly New Hampshire, people with property up there. I spoke with a doctor who she should be in phase 1. She got impatient. She went to New Hampshire and got a shot very quickly. Any thoughts about that?
You're not supposed to do that, but
I mean, she's licensed to practice in New Hampshire.
No, you actually,
you didn't tell me that part. She's licensed to practice in New Hampshire. That's a different answer.
yeah,
In both states.
that's,
She's licensed to practice in both states. That's fine.
Governor, your administration had said at the start of the rollout that you plan to put 20% of doses aside for highly vulnerable cities and towns. Do you guys determine which towns and cities actually are? And do you think you're still going to be able to do this given the continuous constraints on supply?
That's more of your question than my question.
What was the end of it, Matt?
If we are going to dramatically expand our capacity to
Oh,
deliver,
yeah.
what does that mean with respect to the 20%?
right. So the 20% is effective in phase 2, like when we go into phase 2. And as you heard when I said we're prioritizing like pharmacies and I listed off a bunch of, Mattapan, Dorchester, Revere, Chelsea, and there's a bunch of other municipalities. So one of the things that we will do is we will start to use the data that we have to see what the penetration, the administration is of doses, and see where we need to make adjustments and put in more doses into those communities in order to achieve that 20%. So that's sort of like a layer on top of, we get the sites up, right? And then you start to look at where you need to now put in more doses and the like. And it sort of goes back to the question you asked earlier when you said, so I'm assuming you've talked to some local boards of health who've gotten their allocation and it's not what they had been hoping for and had asked for. And so when we get the allocation request coming in, when we get into phase 2, we will obviously be making adjustments on ensuring that those communities receive the 20% and also that they're being used. I mean, that is also one of the things that we clearly need to do is ensure allocations and what's in hand and what's being used. So as we continue to make adjustments, but we are committed to that 20%.
We have a formal list of towns and cities that qualify.
We have a map. We have a map that shows which communities have been most disproportionately impacted by COVID. Yeah.